And we are live. Awesome. So part 2 of the frequently asked questions. We have 5 more questions. In the first part of the video we talked about, which you can find on our website, we talked about what is the popping sound. What else did we talk about?
The treatment plans.
Treatment plans, kind of got into some of the wellness versus what we kind of do here.
And the safety.
And yeah, is chiropractic safe? So if you want to tune into that, you can always watch it on our Facebook page. We're going to get all this stuff loaded up to YouTube as well, so we'll start to promote our YouTube channel a little bit more. But let's get into the second part of this. Our first question is, what type of education and training do chiropractors have? That's one that we commonly get.
There's one of my favorite things is that we hear about or we get referenced from, or people say, "Are you a real doctor?" Yes, we're real doctors. We go through a doctorate program. Chiropractic school and medical school are similar tracks as far as number of years. So it's a 4-year education, or it's in trimesters and quarters depending on the school you go to, but it comes out to about 4 years of education. We pulled some stats just to make sure that we're referenced with this. And this is from the school I went to, Cleveland Chiropractic College out of Kansas City. This study was done in '98, I believe. It was a comparison to medical education to chiropractic education. And basically the contact hours are about the same. The biggest difference is the amount of rotations and internships that the medical students do versus us. We do most of our training in the schools. So we actually see student patients, we see outpatients that come to the schools. We don't do rotations like medical schools. So those numbers are a little skewed just because of that, just because of the number of hours that they're out in the field versus we're in-house with most of ours. But just to compare anatomy and physiology, we get 540 hours. Medical schools get 508. So we actually get more anatomy and physiology. Physiology is basically about the same, 240 to 320. Pathology, geriatrics, pediatrics, we get 360 compared to 401 in medical schools. The big difference is in the diagnosis. We get 630 hours versus 300 in the medical school. That's diagnosis, dermatology, eyes, ears, nose, throat, those kinds of things. And then in radiology, we get 360 hours compared to 150. And in the musculoskeletal realm, we get a significant more amount of numbers as far as the number of hours of musculoskeletal diagnosis, which makes sense because we primarily live in the musculoskeletal world. And there's been some recent studies done on medical schools and their ability to diagnose and treat musculoskeletal conditions, and it's not favorable for the medical schools. And part of that's not obviously their fault, but even though they see a large number of back and neck pains, they're not always as well equipped as they would like to be coming out of school to address those things. So from a musculoskeletal standpoint, we have more number of hours in the schools, and then we have a lot more hands-on diagnosis, orthopedic testing, those kinds of things. Those are all curriculums that we have to go through over and over again in the schools to get through, to take our boards and to get the contact hours that we need to get. So from a education standpoint, we actually have a fair amount of larger amounts of hours in certain areas. And just our contact hours in general in those general sciences is 3,600 hours in the chiropractic world to 2,700 in the medical world. So it's very similar, and in some instances we actually have a little more training.
Perfect. I think the only thing I would add to that is some of the education that we build on, that we in particular have built on, like Corey teaches a ton for MPI and other institutes, and then I've taken a lot of those classes and hope to get into the teaching someday, but it's just we do a lot more. We've kind of expanded our knowledge base from that to get more into the rehab world, the soft tissue stuff. So kind of getting into our next question is, what is the difference between a sports chiropractor and a regular chiropractor? Not that we aren't, obviously we're regular chiropractors too. We see a lot of family practice. We see basically babies to geriatrics, but I think our office is a little bit more equipped to be a sports chiropractic clinic. We are starting to get more into the youth athletes. And I think what makes us more equipped for that and what makes us different to be confident saying we are sports chiropractors is we have those other tools. We have the soft tissue training, the ARTs, the Grastons. We have the rehab training. Corey's gone through the Diplomat program. I've taken a lot of those courses. So we have the exercise and rehab knowledge to kind of implement and have the patients do at home to kind of get them back. So I think that's what is the big difference between why we can feel confident saying we treat athletes both of middle school, high school, and all the way up to the college level.
Yeah, I would echo that. They're really, when you're looking for a sports chiropractor, there's the problem with the profession is that the problem and the strength of the profession is you can kind of do whatever you want to with it. You can make it any kind of practice you want to make. If you want to see pediatrics, if you want to just work in the upper cervical spine, if you just want to do sports type injuries, then you can do it. But there's no one place to go to search and find sports chiropractors. There's no like database of sports chiropractors. So you just have to, again, like we talked about last week, be your own advocate. Ask your doctor questions. Like there's no reason why you shouldn't have a list of questions for your doctor when you go in. A sports chiropractor is going to be somebody that's had some training in those other areas like Dr. Peters just mentioned, soft tissue release, taping, rehab. Like those are the three big ones that they should have some further training in. There's classes out there called FMS and SFMA. That's another one that you want to look for, some keywords. And then the big one would be DNS and ART. Like those are the two other outside classes that we would have other training in, which we all have done at some point in time throughout our school or our past training. But look for those other things that would be a little more down the functional route. And that's not to say that people that take those classes have to be sports chiropractors. I would say the vast majority of my practice is not sports. We see a large amount of runners and CrossFit athletes here, but that's just through relationships that we've built and some niches that we've formed, not intentionally, but somewhat by happenstance. But I would still say that my practice largely is not sports-based. But if you're looking for a sports chiropractor, you would want to look for somebody that has training in those other areas.
Perfect. Moving on. I'll pose this to you, Corey. What is the role of nutrition when it comes to taking care of your patients?
None. You can eat whatever you want and drink. You can drink your lunch and eat greasy food all day long. It's huge, and we've seen it here. It's hard to sometimes implement, and it's a really tough subject to bring up to some people because food is so emotional. But when I was going through school at Cleveland, I took David Seaman's 36-hour chiropractic nutritionist program. So 3 weekends, 12-hour weekends of neurology and basically biochemistry and how the inflammatory process is driven by what we eat. And if we're treating musculoskeletal conditions, we can't necessarily separate the biochemistry from the musculoskeletal world. It used to be one of the things I used to promote myself is that you can't fix a mechanical problem with a chemical solution. So you can't necessarily treat a musculoskeletal disorder that's not acutely inflamed with drugs and pharmaceuticals. I'm kind of going backwards on that. I've kind of come full circle. We can't necessarily treat musculoskeletal disorders with a mechanical answer and not address the chemistry in a lot of cases because the inflammatory process, even if it's chronic, is playing a role in the tissues to the point to where if you really can't get the kind of response that you want to get from the manual therapy world and from doing soft tissue work and joint work and the rehab, then the missing link is almost always nutrition and biochemistry. And so we try to implement an anti-inflammatory approach to treating musculoskeletal disorders because they go hand in hand. You can't have one without the other typically. Now there are people that come here with true just injuries. They eat right, they're healthy, they're super active. Those are easier ones for us to treat because we don't have to address the underlying inflammatory conditions that are driven by food. But our approach here is the David Seaman, the deflame diet here. So there's a little free press for you, Dave. But I took his classes well before this book is brand new. You can go to deflame.com. There's some more free press for you, Dave, to get this book, where you can come in here and borrow my copy if you want to. So basically what it is we try to supplement our treatment with clean eating first. Like we want to eliminate anything that's inflammatory in your diet, which would be here, breads
it's on the back.
Breads and grains.
If you can see all those foods right here, there's Dave Seaman. All these foods.
Yeah, the big ones are breads and grains, sugars. The gluten thing's gotten a huge amount of press to the point to where you know, the paleo diets and those kinds of things are all driven about staying away from gluten. Dr. Seaman was talking about this decades ago about how breads and the breakdown products of breads and grains creates a low-level inflammatory process that just fills up your inflammatory cup to the point to where once it finally spills over, then you express whatever your genetics are predisposed to: cardiovascular disease, cancer, atherosclerosis, liver issues. It's all kind of genetically predisposed, but what drives that genetics is this low inflammatory soup that we keep putting into our bodies through refined foods, through things that are high in breads and grains and sugars, things that our body really wasn't originally meant to process. And so the breakdown products of us processing those foods are inflammatory mediators that just kind of circulate through our system and continue to build up until they finally express themselves in whatever horrible disease you're predisposed to in your genetics. So that's our approach here, is to try to get you to first eat a little bit cleaner. And it's not just wiping things out. We have, you know, I have a sheet that basically helps you kind of take things out slowly so that it's more of a lifestyle change versus a diet. We don't really like the word diet here. And then if you need some more help with supplements, then we have a baseline low-level anti-inflammatory supplementation that we offer here. But if you need more specific testing, then we send that out. We have a couple referral sources here in town that will do like extensive blood testing and find allergies and things like that, and then help guide you down that route. But our approach here is an anti-inflammatory diet with just clean eating, more water, exercise, and then if you need supplementation, we can always go down that route. But that's the role that nutrition plays. Like, we can't separate chemistry from mechanics anymore. It just, and the studies have shown it, that even if we do something mechanically to somebody, it changes the biochemistry, which is really cool and exciting. So it's an aid for us to be able to implement some of these concepts.
And I think as practitioners, and based off of where we are, we're at 156 in Pacific, we kind of share this space with some really good restaurants in Omaha, with Mama's Pizza, and we have Pettit's Pastries and Hector's and Vincenzo's. So we always know we get a really quick reality check if we kind of failed the patient and didn't properly educate them on some of the eating stuff that Corey alluded to. Is because, like, they'll literally walk out of our office like, hey, I'm feeling pretty good, and they take a hard left to Pettit's or a hard right to Mama's, and then it's just like, all right, well, next time we really gotta hammer home some of those ideas that Corey was getting back to. And I think ultimately it kind of comes down to, like Corey alluded to, is the emotional attachment to food. It's like unbelievable. Like, I see it in myself too. Like, we eat bad occasionally, if not more than occasionally sometimes when life gets crazy, but we have to figure out that food is medicine and food is fuel rather than, hey, it's just so emotional and it's addicting, like all this stuff. There's a couple documentaries on sugar and on Netflix that just talks about how addicting it is, like to the level of cocaine. So that's why we need to make it a lifestyle choice rather than try to white knuckle it with a diet, because ultimately if you're doing the white knuckling, you're just going to fail after a certain amount of time. Your willpower will cease and you will give back into that lifestyle. So that's kind of just to add to what Corey was saying. And going back into one of the next questions is, what happens with the chiropractic adjustment that helps decrease pain? We've kind of seen that for years and years and years, that because we're really, really good at treating pain. Pain is what people come to us for most of the time. So I think the big difference is, in what we kind of have figured out with some of the neurology and how that's all expanding, is, and one of the main theories is that information it's afferent, so it's whether it's nociception or mechanoreception. So the nociception would be like the pain. Like, not always does nociception lead to pain, but that's what happens to cause pain. And it's a lack of balance. It's a disafferentation is what they typically say, is we have too much nociception and not enough mechanoreception. We have bad information in, and then the output would be pain, which is always determined by the brain. And I think one of the big things that we do is when we're living in the musculoskeletal world, we focus on the mechanoreception. We're stimulating mechanoreceptors, whether it's in muscles, joints, by manual therapy, adjusting, and we're kind of quieting down the nociception. That's the best way to think about it, is we're turning down the nociception and increasing the mechanoreception. So we're more good information into the brain and spinal cord is going to result in better information out. We're going to have less pain, we're going to have more functional movement, and that's kind of how we focus on it and explain it to patients, because a lot of times it gets really, really complicated really, really fast, and patients don't understand that. Like Corey talked about with some of the chemical nature of it, everything we do from a mechanical standpoint actually has a chemical manifestation in the body, and that's kind of the changes that occur within the brain and spinal cord are actually more chemical in nature, although our input would be mechanical.
Yeah, and that's exactly kind of how I would explain it, to really make it easy for patients. If the nociceptive pathways, which are your pain pathways for the most part, and it's not that simple, but we make it that simple. If that's the hot water, what we do turns on the cold water and balances out that hot water so that you're not burning yourself, is kind of the idea. It's the way chiropractic was explained to me is that we move bones and we free the nerve so that it can do its job on the outside, and that's not what happens when we adjust somebody or when we do any sort of manual therapy. We activate certain receptors that turn off or dampen the response of the other receptors. And it's really powerful to dovetail with David Seaman. He spent a lot of time in the neurology world. He did a neurology diplomate. And so what he wrote was a paper called the disafferentation paper, and it basically shows that we turn those pain receptors off at the cord level in two spots, pre and postsynaptically, meaning where they join in the cord in the front and the back, and then through a loop that goes through the central nervous system that works in the same pathway as opioids. So Oxycontins, Vicodins, those types of higher end narcotic medications as opioid pharmaceuticals, we turn that pathway on. Granted, it's a much lower level. It's a flamethrower compared to the opioid medication is a flamethrower compared to what we're doing. But we're still using that same pathway through the central nervous system to turn off those receptors. So what we do from a pain standpoint is very powerful. But the cool thing in the neurology world is that they're showing that when we adjust people, we actually increase white blood cell production, which is positive. We can make transient changes in blood pressure, which is really cool, and that has to have a chemical sort of response. We increase antioxidant production, which is really exciting. Antioxidants, basically oxidants, are what we ultimately die from, is oxidation or cell death. And so antioxidant production actually decreases and lowers that oxidation or that cell death rate. So that's an exciting thing. And we also know that through some studies, and these are all referenced in classes that I take, and I don't have the references sitting in front of me, that we increase parasympathetic, or we make changes in sympathetic system markers, meaning the sympathetic system is our fight and flight. That's our high stress system. When we adjust somebody or we do manual therapies, we actually take and switch that to a parasympathetic system. So meaning we go from a high stress situation to a lower stress situation, increased digestion, lower heart rate, better sleep, those kinds of things. And so that has to have a chemical component to it, because sympathetic system markers are like your adrenalins, your cortisols, those kinds of things. And we're making changes to cortisol levels over time. We're making changes to the adrenaline and the insulin production that we encounter or we have going on all the time. Basically what we're going for is homeostasis, which is a big fancy word for meaning balance. Yeah. And Dr. Seaman talks about getting into a more homeostatic condition through manual therapy and through nutrition. And ultimately that's what we're doing, is we're changing the input to one that's more positive, in that we turn the nociceptive pathways off, which in turn create these changes in cortisol levels and sympathetic system markers and the bad things that we don't want to have in our bodies, to one that's more balanced, so that we have less of those things and more of the anti-inflammatory type markers, white blood cell production, better heart rate, better digestion, better breathing, things like that. And that's why we get some of these crazy secondary stories that we're not intentionally going after, with better sleep, better respiration, better digestion, changes in all sorts of different things. Kids, not having colic, kids not having ear infections, kids not doing bedwetting. It's really just turning on the neurology of the system and making it more balanced and more homeostatic, if you want to use the fancy buzzword.
So I think one of the interesting things about that with the sympathetic versus parasympathetic and the emotional nature, like trying to tie this all together, like how does it all tie together, is if you ever think about, like I'm treating a teacher right now and she's getting ready to go back to school and her stress levels are through the moon. Well, her pain is like through the moon as well. So it's like we're really trying, we have to balance all that out, kind of talk about some of the stress management. Not that we're therapists, but we appreciate like the whole body approach to healthcare and understanding that stress and emotions play into the pain cycle. So we can't beat ourselves up over knowing that she's doing a little worse right now. We just need to talk about the stress and how kind of help her with some stress management things and how that's going to help her pain, because a lot of times we see that and people, it kind of goes unrecognized. We're always looking for this pathoanatomical diagnosis, like I put them in an MRI or an x-ray and this is what's causing the pain. Well, it's a lot more complicated than that, and we kind of see that with the emotional aspect of pain. And moving on to the last question, Corey kind of talked about, we get a lot of questions about pediatric health conditions like the colic, the ear infections, the bedwetting. By no means is it a huge part of our practice, but we do see it a lot. So I'll just kind of pose it to Corey here. What about chiropractic for pediatric health conditions such as colic, ear infections, and bedwetting? What do you typically say when people come in?
Having kids myself, I'm not going to turn any parent away that's having problems with colic. I've gone through that. I've lived through those sleepless nights before. So, you know, it's there. Dr. Peters has the Bromford report here, and there's no hard evidence to support ear infections, colic, bedwetting, those kinds of things. There's no like direct correlation between manipulation, manual therapy, and those conditions getting better. But because kids are such neurological sponges, meaning their neurology, their nervous system is still developing, they're taking everything in, and they just sponge up all this input. If we can get them to be more balanced, like we just talked about, through manipulation, through manual therapy, then you see these things go away sometimes. I've had success with ear infections. I don't go out there and say, hey, I can cure all ear infections or all pediatric conditions, every sniffle and sneeze. But because of what we do has such a strong neurological effect, you do see responses in kids, and you see it pretty quickly. So my approach to pediatric care is, if you have a kid that needs some help, I use a combination of manipulation and the reflex muscle activation, the DNS approaches, because kids, if you can balance the system through the muscle and access it through reflex points, which they're very reactive to, then you see better responses. But I always tell parents that we're going to know in like 4 to 5 visits if you're getting better, because kids, like I said, are such neurological sponges that if it's going to help, it's going to help pretty quickly. And so you're going to know within a few weeks if it's helping. And so I'm willing to give it a try, because I know, you know, being a parent is challenging enough, let alone being a parent of a kid that has, you know, illnesses of any sort, or colic, or those kinds of problems that you know, bother them, from like the bedwetting thing that's embarrassing. I'm more than willing to help. From a bedwetting standpoint, I'm about 50%. So I've helped 2 kids, and 2 kids I have not. So, you know, sometimes it helps, sometimes it doesn't. I have no references to support why it would help, other than just through the balancing of the system and the changing of like the neurology, taking you from one that's a more high stress, high cortisol, high wind up type situation to one that's a little more balanced. That's my only way to kind of rationalize it for you. But again, if it's going to help with kids, it's going to help pretty quickly.
Yeah, kind of alluding, we don't necessarily tell parents or people when they ask like, hey, we treat these conditions. We're treating the child and some of the functional findings with the muscles and the joints. And then if it happens, it happens. And that's why we're not doing these lengthy treatment plans. Kids are very responsive, they're very resilient. So after 4 or 5 visits, if we're not seeing any changes, then we're going to be like, okay, well, you're probably not going to see changes with what we do. These are all non-musculoskeletal in origin, and we live in the musculoskeletal world. The majority of our practice, that's why Corey said 4 bedwetting cases in however many years of practice. So it's not something we see frequently, but we get questions about it constantly, because there's a lot of chiropractors out there that kind of build their practices on this, which is fine, that's great for them. We just feel we're a little bit more evidence-based. We feel a little bit more cautious kind of proceeding and saying, hey, we treat this, we fix this. The research it's out there, it's inconclusive, but even the Bromford report kind of says it's favorable. So it'll be interesting to kind of see where this goes in the future. They actually did a systematic review that even built on the Bromford report. So what we kind of had referenced in the past, the evidence report for manual therapy, is they're studying that even more, and more research is coming out. It's inconclusive, but it's favorable for some of these pediatric conditions that we talk about with the colic, ear infections, and bedwetting.
And I will kind of dovetail that just briefly because of some of the things that we do here, the DNS approaches and some of the reflex muscle activation training that we've had. We do see kids that have developmental disabilities like cerebral palsy, Rett syndrome, so Angelman's disorder, things that are developmental in origin. We can help you with that, and it does really help with respiration especially. It helps with the muscle tone issues that kids with cerebral palsy have, and it's not a manipulation heavy treatment type session. It's more of a reflex muscle thing, accessing that system, getting the tone in the muscles to change. And it can be very beneficial from just a management standpoint. We're not going to fix cerebral palsy, obviously. We're not going to, we don't cure cancer. We're not going to change developmental disabilities. We're not going to change things that are structurally altered because of development. But we can help you manage those things through some of the things that we do here. That's kind of what makes us somewhat unique. And that's where like the value of what we do has really hit home to me, is that we really don't know what the value of our therapy and our services can be sometimes until you see a parent or a kid respond to these things, and just, it kind of helps their life, be a little more functional and live a little better life. So the value of that can't sometimes be measured in dollars or insurance dictation of what gets paid for those kinds of things. So I would like to kind of finish that as some points that we don't fix anybody. Jace brought up a good point there in the Bronford report, is that we're here to, bodies are more like gardens than they are like cars. Everybody wants to be fixed, and we can't necessarily fix things. We can just help you function better so that your body can kind of respond and make the adaptive changes that it needs to be made. Some of that has to be through nutrition, some of it's through the manual therapies and the rehab and the things that we do here. But if you're looking to be fixed, that's not always the case. Like, we're here to change the function, which will ultimately lead to the symptoms going away, and for you to be more functional so that the symptoms don't necessarily come back, because your body is more like a garden. Like, we have to make changes from the inside out versus taking parts apart and putting them back together. So just know that we're here to help you the best we can. We don't claim to fix anything, but we do want to help you function better and hopefully live a better life, and one that's a little more pain-free, obviously, but also that's a little higher functioning. So just to kind of put a little bow on all that and wrap that up there for you. So I would encourage you, if you want to join we have a newsletter that goes out every month. If you want to be a part of that newsletter, just go to our website, omahaspinesport.com. There's a newsletter section. You can just put your email address in, and you'll be added to a newsletter list. And if you have any other questions, you can also go to the Omaha Spine and Sport page and ask questions there. That email comes to me, so I can help spread that out to the other docs and get some questions answered for you. And we're going to continue to do these live feeds on a weekly basis. So if you have questions, just scroll across the bottom. Jace will read it, because obviously I cannot see it.
We have a question right now. It's, what books are you guys reading right now? From Taylor.
Good question, Taylor. Jace?
What am I reading right now? I just got done with my third McKenzie course, the MDT stuff, so I'm trying to go through a lot of that and hammer home some of the principles as I'm seeing patients and applying some of those concepts. So very clinical right now. I kind of bounce back and forth between the clinical, and I'm like a nerd self-help kind of thing, like happiness advantage, like all that kind of stuff. So I try to balance it out, because sometimes when I'm reading those self-help books, I'm like, man, clinically, I need to read some stuff clinically. So I'm constantly floating back and forth. So right now, I'm kind of going through some of the MDT stuff, applying it to my patients, and then getting into some other of that self-help kind of stuff.
I am reading right now. I had pulled this out of my bag, so when I travel, I always pick a clinical book to read, and then a non-clinical book. So right now, I'm reading the Deflame Diet. I'm going through different chapters. I'm really interested in what he has to say about cholesterol. It's amazing what myths and misconceptions are out there about cholesterol. So I'm reading this right now, and then I'm reading a book called Mindset by Carol Dweck. It's about how fixed versus growth mindsets, people that succeed always have a growth mindset, meaning they see challenge as stress as a challenge, and they see failure as a way to grow versus a reason to, or an excuse to quit. And it's a really good book. I would recommend you get the book. I'm listening to it because I listened to it, and the author has a very unique voice. She's it sounds like a drunken Siri, so it's really hard to kind of get through, but it's really good. So that's what I'm going through right now, is a book called Mindset and the Deflame Diet. And then I'm always picking up Paddle's book called Clinical Rehab, and always thumbing through that, because there's just every chapter's got really good clinical information in it. So that's what I'm reading.
We are always open to recommendations, so if you're reading something that you really like, just let us know.
You're welcome, Lori. Lori and I used to work together at the Ruska Spine Center. She said, thanks for the information. It's appreciated. Well, we appreciate you watching. We actually have viewers this time. We didn't have... Taylor, I think, watched last time.
But we never had any contact.
But we couldn't tell, so...
So we're kind of figuring out our video stream. We'll continue to do this on hopefully a somewhat regular basis. If you shoot us questions, we'll always address them in our live broadcast. Otherwise, we'll kind of just come up with stuff that we see in the clinic or hear about in the community. So let us know if you have any questions.
You can even post them to one of these Facebook posts on our Facebook page too, if you want to. So we'll try to address as many. We'll come up with topics every week, and if it's something that you enjoy, let us know, and we'll keep doing these things just to keep you informed.
Awesome. Thank you.
Have a good week.